Okay, so let's get started. Next slide, please. So good afternoon. Thank you for joining this webinar series. We are going to be talking today. This is our August installment. But before we get to that, we want to talk a little bit about our repository and give you an overview of what we've been doing. So the repository, we're here to facilitate sharing and use of data and biospecimens and other resources with the research community. Right now, our repository is being able to facilitate access to over 50 million data images, over 8 million data sets, and 60 million biospecimens. We have registered users over 7 million, and weekly users that go over the 5 million. Our users have produced over 800 manuscripts, and you will be hearing today from some of them that have been able to produce very impactful results. Next slide. The NIDDK Central Repository is part of the broader NIDDK data sharing ecosystem. We make resources, different types of resources available within the NIDDK Central Repository, but we also connect to different resources outside of the NIDDK CR and also partner with other systems to really strengthen the NIDDK and the NIH data fabric. We have many that have already been implemented and others that are in progress. Next slide. Many of those things are part that we are working on and will be for future functionalities. We have been working on a data challenge platform and an analytics workspace. That workbench, we hope to provide you with some insights in future webinars. But right now, the analytics workbench that we've been working on, we hope that this streamlines end-to-end data science lifecycle and really enables and facilitates discovery of data-driven research. We hope that our investigators and really links that or really bridge the gap of researchers and enables and facilitates collaboration. It minimizes data movement and really drives NIH mission. Next slide. About this challenge series, we started this project with the aim to develop tools and approaches, also models and other methods to increase data interoperability, also to maximize the usability of our resources for AI and ML applications. Today, you're going to be hearing some of the uses that our requesters have been able to use in terms of AI ML, but we are also trying to do things with innovative approaches with this data-centric movement. Next slide. The secondary data science and Meet the Expert series are looking to really educate the community about what we are doing and also educate the next generation of data scientists. We meet on the last Thursday of every month, and next month we are going to continue the conversation on the real-world data linkages with a focus on quality and reusability of those record linkage approaches. I encourage all of you to visit our website and look at information on past presentations and also to register for future presentations. Next slide. Today, I'm going to present to you right now our experts for the day who are requesters, approved requesters from our repository. We are going to present to you Dr. Adam Guerra, who is an associate professor at the University of Louisville. He specializes in nephrology and hypertension. He has advanced degrees in engineering and computer science and clinical sciences. His research focuses on applying artificial intelligence and machine learning to personalized kidney disease treatment. He developed one of the first AI-guided clinical decision support systems for anemia management in dialysis patients, and now this is used clinically and commercially. His current work uses AI/ML to better understand disease processes and discover new therapies. His work was performed, some of the work with the use of CRIC data from the NIDDK Central Repository. Also, next slide. Today, you're going to be hearing from Dr. Juliette Emanuel, who is an associate professor of surgery and immunology at the University of Southern California Keck School of Medicine and a liver kidney transplant surgeon at Keck Hospital and Children's Hospital in Los Angeles. She also serves as an associate chief of clinical research in the Department of Surgery with an MD and PhD degrees from the University of Alberta and advanced surgical training at Emory in Alberta. She leads an NIH-funded lab studying immunological factors in liver transplant recipients, and her expertise includes computational biology and associated liver diseases in living donor liver transplant. Some of her research involved the use of PALF data, also from NIDDK-CR. Next, we are going to be hearing from Dr. Prasanna Santhan, who is an associate professor of clinical medicine and oncology at Johns Hopkins. He specializes in endocrine disorders, particularly thyroidology, thyroid neoplasms, and metabolic bone diseases. He holds medical degree from Medical College and NHL Municipal Medical College in India. He has advanced residency training in internal medicine. He actively contributes to professional organizations such as the American Thyroid Association and the American Board of Internal Medicine. He's a leader in endocrine research and focuses on metabolic syndrome. He has also co-founded the AI MedApp LLC, which develops AI-based solutions for metabolic imaging and cardiometabolic health. Some of his work was developed with the use of look-ahead data. And without any further delay, I'm going to leave it to the first speaker, Dr. Guerra.
I'm bringing up my slides. Are they on?
Yes, they are.
Yes.
Awesome. Thank you. Thank you for this nice introduction. The title of my presentation today is Opening the Black Box Toward Understanding Pathophysiology of Uremic Vasculopathy Using Explainable Artificial Intelligence Models. This talk is focused on my work with Dr. Eleanor Leder at the UT Southwestern. It is based on the data provided by the chronic renal insufficiency cohort from NIDDK Central Repository. And the meaning of opening the black box in the title is twofold. We are trying to gain better understanding of the pathophysiology of a uremic vasculopathy, which is one of the major complications of chronic kidney disease, by opening the black box of the AI models that are typically difficult to understand. This is the outline of the presentation. I'm going to start by giving a brief overview of uremic vasculopathy of chronic kidney disease. Underscoring the importance of understanding the pathophysiologic mechanisms of it, in hope of coming up with better diagnostic tools, prevention, and treatment. Next, I would like to go over some challenges related to data scientific approaches in biomedical computing. Some of these challenges we are facing with this particular problem, with this data set. And what I'm going to do is I'm going to propose the use of artificial intelligence methods as one possible way to solve some of these challenges. I'm going to demonstrate from the perspective of an artificial intelligence researchers how we develop and apply these methods in order to gain better understanding of complex multifactorial physiologic processes. So uremic vasculopathy, what is this? This is a multidimensional disease process that evolves over the course of chronic kidney disease. And we all know that cardiovascular damage, as shown on these bar plots right here, is one of the most important morbidity and mortality factors in chronic kidney disease. Therefore, in order to improve the lives of patients with chronic kidney disease and extend their lifespan, it is important this is one important comorbidity that needs to be treated. Why is uremic vasculopathy a difficult to treat disease? It is because the development of uremic vasculopathy starts early in the early stages of chronic kidney disease through progressive endothelial damage, smooth muscle cell damage, and connective tissue dysfunction that lay groundwork for the final stages of vascular calcification, which is, as mentioned earlier, which is one of the key factors driving cardiovascular mortality in chronic kidney disease. We are departing into this research endeavor by postulating that early stage uremic vasculopathy is primarily driven by abnormalities in lipid metabolism, inflammatory processes, and endothelial dysfunction processes. We also claim that the late stage of uremic vasculopathy at the late stages of chronic kidney disease are primarily driven by abnormalities in mineral metabolism. So we are using the Crick data to sort of test these hypotheses, or possibly generate new therapeutic hypotheses that we expect to test later. So our claim to fame, our main statement is that effective diagnosis, treatment, and prevention of uremic vasculopathy will require better understanding of all these various pathophysiologic processes behind it and how they contribute through all different stages of chronic kidney disease progression. Now let's switch to the data science part of the talk and outline some challenges that we are facing in this project. So as I mentioned, uremic vasculopathy is a complex multifactorial process, very much like most, if not all, of the physiologic processes that we study. Two important components, two important challenges with this project, as well as with other biophysiologic modeling approaches, is that we are dealing with high-dimensional data. Typically, with high-dimensional data, we have lots of parameters and a relatively small sample size. One important caveat that I need to mention here is as we increase the number of parameters, number of biological parameters that we study, we increase the likelihood of missing data occurrence. And current biostatistical methods don't have very effective means to deal with this problem. This is something that I will like to return to, I'd like to touch upon as I present the methodology that we use. Another important challenge in modeling biophysiologic processes, if we have a large number of parameters, there are likely to be interactions between individual parameters as well as groups of parameters. One important kind of interactions that makes modeling these processes challenging using standard biostatistical tools is the presence of negative feedback loops in many of the physiologic processes. In light of these challenges, we think we can help solve them using some of the tools provided by the field of artificial intelligence. What actually is artificial intelligence? The definition, there is not a well-established definition right now, but the one that we like to use is the one shown on the slides, is where we refer to artificial intelligence as multidisciplinary field of science that translates human problem solving and cognitive skills into the digital domain. And here I'm just outlining three main important human skills that we would like to refer to: learning and adaptation, pattern recognition and abstraction, planning and decision making. In this talk, we'll be focusing mostly on learning and adaptation and somewhat on pattern recognition and abstraction. So let's look at what tools we have in AI from the subdomain of machine learning. There are essentially three main learning methods that are currently used in all of the state-of-the-art AI approaches: supervised learning, unsupervised learning, and more recently, self-supervised learning has been introduced, which combines features of both supervised and unsupervised learning. There's also a method called reinforcement learning. This one, however, is outside of the scope of this presentation. This is a brief overview of what supervised learning is. Given X and Y, find mapping from X to Y. And here I'm showing a list of very familiar looking models that are based on supervised learning. Supervised learning, in my opinion, is very much like learning to pass the test. Give me a good answer, I don't care how you do it. Unsupervised learning, on the other hand, is more focused on understanding the data. So given a similarity metric, find patterns that show relationships between parameters. Again, supervised learning, learning to pass the test, given X, find Y, I don't care how. Unsupervised learning, find patterns of similarity within the data in an attempt to understand it. Autoencoders, on the other hand, are a form of self-supervised learning introduced within the last decade, more or less. These tools, autoencoders, they combine the features of supervised learning and unsupervised learning. And here is how it happens. Let's say we have our data combined in a vector X. Let's assume that that these data are high dimensional, let's say 100 dimensions. Traditional statistical methods have trouble dealing with these type of high dimensional data. How would we, as humans, solve a complex high dimensional problem? We do it through simplification. We always simplify a complex problem into a simpler one that we know how to solve. That is the process of abstraction. So this is what exactly happens inside an autoencoder. We take a high-dimensional input data, and we process it through multiple layers of neurons called encoder, down to the layer called bottleneck, which essentially tries to capture all of the relationships between these high-dimensional data X into a much smaller dimensional space. Now, how do we accomplish that? So this is the unsupervised learning part. How do we accomplish that? We train this model to take the high-dimensional data, input data, into a low-dimensional representation, and then we take the low-dimensional representation and try to reconstruct the original input data. That is the supervised learning. So whereas in supervised learning, we provide X and try to find Y, whereas in unsupervised learning, we provide a similarity metric. This approach combines them both. We do not have to provide a similarity metric to this model. We let it figure it out on their own. One important component of this approach that we have started using is this part where we perform fuzzy encoding of the input data. Essentially, we transform the variables in X into a 0-1 domain. What the benefit of this approach is we have every parameter encoded into a 0-1 domain. And what's more important is if we have a missing data point, such as an X3 over here, we can easily encode it by activating all of the fuzzy encodings of that parameter for that case. So we can seamlessly incorporate missing data in this approach. Now, the most important part, we get an encoder. So what? We are able to predict X from X. We have some low dimensional representation of it. What good does it do to us? We need to open the black box, i.e., we need to look at the latent space created by this low dimensional layer of the autoencoder and figure out if there are relationships inside it that we can project back into the input domain, hoping to find interpretations. So this is the crux of this work. Whereas all of these AI models, and especially autoencoders that are being used by everyone, they're black box in nature. Our goal here is to help us extract meaningful information out of this model to help understand the processes that are going on behind, in our case, uremic vasculopathy. So this is a select list of biomarkers that we have used in this study to help figure out the mechanism of uremic vasculopathy. We formulated this problem as predicting the probability of coronary artery calcification score being greater than 0. And we use select biomarkers representing the processes of inflammation, lipid metabolism, endothelial modulators, and mineral metabolism that are all available in the CRIG cohort. So this is an example of what the latent space inside a trained autoencoder looks like. And here specifically, we are looking at clustering the latent space into 3 clusters or 10 clusters. This is the number of clusters here is decided by the user depending on the granularity of information that we want to extract. And as you see, these latent features, again, going back to the black box nature, these latent features don't really carry a meaning for us, but we will try to project them back onto the input space. And when we do this, we are able to extract factors that are essential, that are essential in predicting CAG probability of CAG greater than 0 at different GFR levels. So here's a table showing factors that we have identified that play a key role in determining the likelihood of vascular calcification at different stages of GFR. So we see that at high GFR and at medium GFR, there are differences between males and females in the propensity of cardiovascular of vascular calcification. This effect is not so much present at the low GFR stages. We see that the intake and excretion of phosphate may be important at high GFR, something that we may elude our attention. We see that lipid metabolism is important all across the board. We see a little bit of inflammatory markers showing up here, and a lot of inflammatory markers showing up here. And last but not least, we also have access to some metabolite measurements in the CRIC cohort that we have included in this analysis. And these metabolites show as important across different ranges of GFR. We are currently working on providing meaningful interpretation for these findings. And this is outside of my area of expertise, so I cannot provide any commentary on that. One important component of this analysis I would like to mention is that not only can we find what the important factors are, but through the cluster analysis of the trained autoencoder, we are able to extract correlation between these parameters and the groups of parameters. So that hopefully will help us create meaningful mechanistic explanations. In summary, uremic vasculopathy is a complex, multidimensional process that evolves over the course of chronic kidney disease and has a tremendous impact on cardiovascular mortality. In order to diagnose, treat, and prevent this disease process, we'll have to gain better understanding of the pathophysiology of it. Just like with all of the biomedical modeling, we face some of the challenges related to interactions between parameters and a large number of parameters. And here we are hoping to we show that some of the human-inspired computing methods may offer attractive solutions to help address these challenges. I would like to acknowledge my collaborators on this project, especially Dr. Leder, who's the principal investigator and funded through the Department of Veterans Affairs. And I would like to acknowledge and thank NIDDK Central Repository for giving us access to this data set. Thank you.
Dr. Emanuel?
Sure. Can you guys see my slides?
Not yet.
Okay, hold on. Let me do that again. Now you can see it, right?
Yes. Thank
Okay,
you.
perfect. Okay, well, thank you for having me. My name is Julietta Momley. I'm a transplant surgeon, and my group has used the PALF data repository to study acute liver failure in children. So I don't have any relevant disclosures. Pediatric acute liver failure is really one of the most challenging patient populations that we have in pediatric liver transplantation. It's the most common indication for liver transplant in children is having genetic problems with the formation or growth of the bile ducts, things like biliary atresia, or PFIC or Alagille syndrome, and that represents about half the kids that we do transplants in, usually under the age of 2. But then we have this entity called acute liver failure, and more than half the time, it's indeterminate, which means we don't know what caused it, versus things like drug injuries from Tylenol or viral injuries. And so how do we diagnose it? We use clinical variables. We look at markers of liver injury, things like AST and ALT. We look at liver function with coagulation cascades with the INR. And then we use encephalopathy, which is a degree of confusion, and being obtunded, which is really difficult to measure, especially in small children. And so what happens is that these children get admitted to the hospital, and we look at these things like their cognitive status, their renal function, their coagulopathy, and every day we decide, should we wait or should we move forward with transplant? The next day comes, are they getting better? Are they getting worse? The next day comes, are they getting better? Are they getting worse? And about 70% of these kids can recover from acute liver failure, even if they're extraordinarily sick in the ICU on renal replacement therapy, on a ventilator, for example. About 15 to 20% will need emergency liver transplant, and a subset of them will get too sick to transplant and have things like cerebral edema or multi-organ failure. And so the NIDDK supported a very large consortium to study acute liver failure in children called the PALF Study Group. This was started in 2000, initially with 20 sites, including Toronto and Canada, and the rest were in the US. Our center, Children's Hospital Los Angeles, despite being one of the busiest pediatric liver transplant centers in the country and the only freestanding safety net hospital in the US, was not part of this PALF study group, which actually helps us with our research questions. But they formed this consortium to kind of study the natural disease process and try to find interventions, and collected a lot of data and samples over about a 15 or 16 year period, and involves overall about 1,500 patients. It's subsequently, this group of investigators have a new study going on right now called TRIUMPH, which is a intervention using either high-dose corticosteroids or lymphocyte depletion in children who present with acute liver failure, as an ongoing study, and our center is part of that study. So I became interested in this. Clinically, we see these patients a lot, and I had a fellow in the pediatric gastroenterology and hepatology program. And this, during the pandemic, there were these reports of acute hepatitis and concerns about COVID causing acute liver failure in children, or maybe adenovirus. And so it kind of made us think about it from a scientific perspective. Can we predict which patients with acute liver failure will recover versus those who need a liver transplant? And then can we also understand facets of the biology of this disease? And so there are a few different scoring systems to predict clinical trajectory in PALF. One of these is the PELD score, which is the Pediatric End-Stage Liver Disease score. This was really designed to predict waitlist mortality in children with chronic liver disease, not acute liver failure. It uses the serum bilirubin number, INR, albumin, objective measurements of growth failure, as well as age. It's for under the age of 12. And it really does not reliably predict death in PALF at all. And honestly, even in chronic liver disease, we use this to rank kids on the waiting list for liver transplant. But most of the kids on the transplant waiting list get what's called a PELD exception, where you write a story about what's been happening with that child and ask for extra points to get them extra priority and move up the waiting list, because we think that the risk of dying is not appropriately estimated by the PELD score. Then there's something called the King's College Hospital criteria. This was designed for acute liver failure, generally in adults. It uses prothrombin time and any three of the following, regardless of hepatic encephalopathy, their age, the etiology, whether it's drug-induced. It's pretty reliable for Tylenol-induced drug injury, for example, and then the duration of jaundice and so on. And again, this score really does not work well for children. Then there is one called the Liver Injury Unit score, LIU score. This was designed to work for PALF. The problem with it is that it works best when you have a peak serum bilirubin, INR, and ammonia with a reasonable predictive value with a C-index of 0.81. But how do you know when you're at the peak clinically? It's more representative retrospectively. And the admission test had a less performance metric. And so our objective was to create a model based on admission clinical variables from our large center that can accurately predict clinical outcomes in PALF. And we wanted to avoid subjective things like measurement of hepatic encephalopathy or confusion. And we wanted to avoid time-based, i.e. duration of jaundice. We wanted to avoid peak values. We really wanted to evaluate common clinical demographic variables and lab values. and to generate an easily interpretable score that doesn't require statistical understanding. And really, our ultimate goal was to facilitate referral to a transplant center. And so my clinical fellow, she would get calls from the transfer center and say, there's this child, they look like they have acute liver failure, they're 3 hours away, they don't seem that sick. Can the parents just drive them to your center, or, rather than waiting for medical transport? And so we wanted to have a score that like an emergency room or a family doctor could use and call us and say, the score says this, and, it seems like they're going to maybe need a liver transplant, and let's expedite their transfer to your tertiary care center. So we looked at our patient population at CHLA. We used ICD and ICD-10 codes to look over a 20-year period, and using the NIH acute liver failure study group criteria, we came up with an ultimate patient cohort of about 145 patients. And when we looked at the demographics amongst these 145 patients, you can see that we had about 60% who survived without transplant, survival with native liver. We had 31% who underwent liver transplant and 10% who died. Among these, the overall rate of listing was 57%. The average age of admission was about 6 years old with a fairly wide range. They were slightly more female than male, ethnically diverse, and again, our indeterminate etiology was about 40% of our cohort. And we had other etiologies like autoimmune, infection, and drug-induced. So we first looked at the evaluation of the individual variables by clinical outcome, and we looked at common labs that are routinely ordered in patients when they present to the emergency room. So the liver function panel, AST, ALT, alkaline phosphatase, which is ALP, serum albumin, ammonia, which is we use as a marker of encephalopathy, total bilirubin, INR, coagulation number, and GGT, which is gamma glutamyltransferase, which is sort of a biliary marker. And what we observed was that these 5 values did demonstrate some statistical significance in differentiating from those who survived with native liver, shown in blue, those who were transplanted, and then those who expired. And so the other kind of caveat to doing this kind of an analysis is that the decision to move forward with transplant or not is a clinical decision. And so there are always some children who were transplanted who may have survived with native liver, for example. And so that can create a bit of a confounder, but nonetheless, we came up with these 5 values. And so we wanted to build a predictive model. So we excluded variables without statistical significance from the initial analysis. We created a correlation matrix of the remaining variables to avoid issues with multicollinearity. And then we log transformed the data and we randomly split them into training and testing sets at a 75-25 ratio to evaluate the internal model performance. I have a data scientist with my team who did most of the statistical work for us. And then we perform modeling based on clinical outcomes using demographics as confounder variables. And so we modeled as a 2-class comparison, and then we used a lot of different techniques, including classical multinomial logistic regression. We looked at random forest, SVM, linear discriminant analysis, and so on. And then this is where we access the data from the PALF study group repository to serve as an external validation cohort. So this included about 450 some odd patients and had similar demographics to our cohort. And remember, our center wasn't part of this group, so it actually is the ideal reference group for our experiment. So we ended up using bootstrapping with a lasso regression with take one out internal cross-validation to build our model. And we've used this for a lot of our data sets, and this has worked very well for us statistically. And so when we did this modeling, we observed that the admission variables of albumin, ammonia, and total bilirubin were the ones that were the best fit for the final model. It performed very well in predicting survival with native liver with a C-statistic of 0.83. And what we did for this is we did 2 clinical outcomes, either survival with native liver or liver transplant and death as a combined metric, because both of those would require, indicate severity of disease and have prevent class imbalance. And so we had a good AUC, we had a good accuracy and performance to confirm the model's predictive accuracy. And so what you can see here on the left is our training ROC, and on the right is our validation ROC with the NIH PALF study group data. And ultimately, this is the model that we move forward with. But as a clinician, I need something that my partners will actually be able to understand and use easily. You know, I told you about the PELD score. We have the MELD score for adult patients, and clinicians can really understand a very simple numeric score. And so we did compare our model to the other tests I told you about, for example, the liver injury unit test, and we had our model outperform that. And so we ended up turning it into a score that ranges from 5 to 60. And with this score, an inflection point of 30 indicates that if your score is above 30, the chances are higher that you will need a liver transplant or die than those without. And so the way that we kind of clinically interpret this is that a score over 30 should facilitate an urgent transfer to a pediatric liver transplant center for evaluation. And so the kind of practical aspect of that is, as a center, if we get a patient in who has a score greater than 30, we can initiate a transplant evaluation and list the patient immediately upon arrival, and then continue to make a decision on a daily basis whether we move forward with a transplant, and not have a lag period where we haven't listed them and we miss out on organ offers as a patient is deteriorating. So the strengths of our study is that we had a large sample size in both the training and validation cohort. We have a very ethnically and clinically diverse patient population at CHLA. And one of the things that's a strength of our data set is that this was a real world experience, with not all of our patients being evaluated for liver transplant or being part of a study. So it's the actual patients who came in and got that diagnosis at our referral center. And as well, the model relies on easily and frequently ordered admission lab tests. Some of the weaknesses is that we did have a class imbalance with the clinical outcomes, which can impact the statistical modeling. And that means, you know, that we had many more patients that survived with native liver than those who underwent liver transplant or died. And then, as I said before, some patients who died may have survived with liver transplant. Some patients who could have survived without transplant may have undergone liver transplant. So it's imperfect in terms of, you know, the actual clinical outcome. So what we observed was that the CHOF score accurately predicts survival with native liver using common admission labs, and it's novel, it's externally validated with the PALF study group data, and we think it offers a very reliable measure of SNL and can guide early referral for transplant evaluation. I don't think it tells you whether you need to move forward with transplant, but that's something that we are exploring. So this was published in the journal Transplantation, and we made a QR code and an app that's accessible on a phone or on the web that can easily have these lab values plugged in. It'll predict this, tell you the score and tell you the probability of survival with native liver. In the real world practice at our center, we looked at the next approximately 30 patients after we completed this study, and it accurately predicted the clinical outcome in all but 4 patients. And those 4 patients, their scores were right around 30. So there were 2 patients with scores of like 28 and 29 that would predict survival with native liver. They ended up getting transplanted within a few weeks, not immediately. And there were a couple of patients whose scores were slightly above 30, 31, 32, who ended up surviving with native liver. And, you know, when you're in that range, you're sort of in the flip a coin spot anyway. And so we feel pretty happy with the performance of this. And because it's been fairly reliable at our center, our clinicians have rapidly adopted its use. So where we're at now is that we're doing a multi-center real-world validation, and we're going to include time series data. So we track it prospectively over a period of days following admission to determine if it can further help refine the need for liver transplant. And we're doing this with collaborations at King's College in the UK, Columbia, and Kansas City Mercy Children's Hospital. And then we were approached by a pediatric ICU collaborative in the UK. They have regional referral for children with acute liver failure, and they wanted to look at the application of this score at the time of ICU referral and transfer. And so that's another study that we're working on from the CHOF score. So we have used this data for additional studies as well. And so another project that we performed with using the same strategy of interrogating our CHLA experience and then using the PALF study group data to validate that is we looked at the impact of social determinants of health, things like financial status, race, ethnicity, spoken language in the home, and amount of social support to determine if that can impact clinical outcomes in children with acute liver failure. and that we observed that there were important differences. So if you had less support, less caretaker employment, or if your family did not speak English at home, this was associated with worse outcomes in these patients. And we're a pretty experienced center. We have a very diverse team, but it made us think about our approach to these patients in our own transplant center, and we can't really have a one-size-fits-all approach to educating the family about this devastating and very acute health problem in their otherwise healthy child. And so it's made us kind of reevaluate that we have to spend a bit more time and have a bit more understanding of the barriers that these families and their patients and their families may be facing during this acute illness and the potential need for liver transplant. The other thing that the PALF study group did was that they looked within the tissue and the blood to try to find, biomarkers and pathologic features that can help, ultimately lead to new treatment options. And the TRIUMPH study that I told you about, that's a ongoing intervention with steroids and lymphocyte depletion, is based on some of this work. And so what they found was that there is a CD8 enriched T cell population within the livers. It's a very inflammatory process, and that you can track some of these within the blood. And so my lab, what we do in our translational space is we look and use systems immunology and systems biology approaches to look at biomarkers of rejection in liver transplant patients. And we're also using that with plasma proteomics and so on. And with our spatial biology techniques, we actually built out an entire pipeline for working with immune-enriched spatial proteomic data. And so this was an ideal application for us to bring in our PALF samples from CHLA, and then consider working with the data and tissue within the PALF study group repository at NIH. And so we have a study ongoing right now where we have samples from about 100 patients, including 66 with PALF in the liver, as well as matched blood samples, where we're doing a multi-omic and systems biology approach to characterizing diagnostic features of the disease and predictors of clinical outcome. And so we did interrogate the repository. Here's an example of the report that they gave me. And so in that repository, they have a very low number of samples and participants who recovered, where we have 25 at CHLA. They had 11 here, but it still could potentially serve as an external validation cohort for the data that we generate in our translational work. So for us, the NIDDK PALF study group data and tissue repository has been a really valuable resource to augment and validate our single center series study and experience at Children's Hospital Los Angeles. And we use the clinical data to generate a new predictive model for management of children with acute liver failure, and to determine, the impacts of social determinant of health on clinical outcomes, and even change the way that we approach this challenging patient population at our center. And lastly, we're considering using the tissue in ongoing translational science studies to understand the pathophysiology of disease. So this is my team and our funding, and happy to chat or take questions or reach out to me afterwards via email if you wanted to chat more. Thank you so much for the invitation.
You may start.
Yeah, so thank you so much, Dr. Rodriguez, for the invite. So today I'm going to talk about the research that we published. It's AI and body composition, novel methods to improve accuracy. So this is an article we published last year, has been, in discussion in different circles, especially with AI in healthcare and medicine. The background is obesity is major public health challenge globally, linked to diabetes, cardiovascular disease, fatty liver, and cancer. Rising prevalence due to socioeconomic disadvantages, lifestyle changes, and reduced productivity. Traditional metrics like weight and BMI have limited sensitivity, high variability across ethnicities. Asians have high body fat percentage for the same BMI, making BMI inadequate for cardiovascular risk stratification. Waist circumference is a strong predictor of cardiometabolic risk than BMI. Stronger waist circumference more than 94 centimeters in men identifies high risk for CVD disease with high degree of sensitivity and specificity. In the Look Ahead NIH funded study, waist circumference increased during intervention predicted higher cardiovascular disease risk. Better predictor, even in children and older adults, trajectories correlate with type 2 DM onset. Despite evidence, waist circumference is rarely measured in routine practice. Measurement variability and site differences affect prevalence and estimates. Guidelines recommend waist circumference as a vital sign, but standardization is lacking. AI offers an alternative to predict waist circumference from readily available variables and indices. Conformal predictions. So normally in different AI techniques, there is point prediction where we predict a particular value or an event, but that does not usually have confidence intervals like traditional statistics. Random forest, XGBoost, support vector machines, they're all associated with machine learning methods with point predictions. But uncertainty is often unknown. What is the confidence? So a new AI technique called conformal predictions. Conformal prediction with uncertainty quantification is what we are interested in. Conformal prediction is a distribution-free framework for quantifying prediction uncertainty in machine learning, offering valid confidence sets or prediction intervals under the assumption of data exchangeability. Unlike conventional point estimates, CP provides guarantees on error rate, making it attractive for high-stakes applications such as medicine and finance. It gives you distribution-free guarantees. CP does not require strong distributional assumptions like homoscedasticity and variance assumptions like traditional statistics, and ensures coverage probability holds on average across future predictions. So uncertainty quantification by constructing prediction sets and intervals, conformal predictions explicitly communicates model uncertainty instead of a single deterministic prediction. Model agnostic applicability. CP can be applied to any machine learning algorithm, serving as a wrapper around the base model. Calibration via non-conformity scores. Predictions are assessed using a non-conformity measure, comparing new insistence to calibration data to adjust prediction intervals. Practical utility, widely explored in healthcare AI for risk stratification, diagnostic support, and survival analysis, where calibrated uncertainty estimates are crucial. So what are we doing here? For the first time, we applied conformal prediction to anthropometry obesity research, provides prediction intervals instead of single point estimates, addresses uncertainty critical for clinical adoption, and extends prior conformal prediction work to metabolic health. We aim to develop a machine learning model to predict waist circumference using demographic and anthropometric data, employ uncertainty quantification using conformal prediction, validate across data on people with diabetes and general population, which is the enhanced data set. Hypothesis. Conformal prediction provides robust waist circumference estimates with clinical utility. So data sets and variables. First, we took the enhanced data set. There were 38,000 individuals after exclusions. And then we applied it to the look-ahead data set, which is the NIH-funded 8-year follow-up study, baseline data used for external validation. So it was a randomized controlled trial of lifestyle intervention in type 2 diabetes mellitus patients. Predictors, we used age, gender, weight, height, race, ethnicity, education level. Race, ethnicity were collapsed into Hispanic, white, black, and others. Education collapsed into 5 categories. Gender-specific models due to distribution in fat, differences in fat distribution. So methods. The goal was to predict waist circumference with confidence intervals. Conventional machine learning regression gives single estimates, no uncertainty quantification. Our approach was apply conformal predictions and giving intervals reflecting uncertainty. adaptive intervals, narrow for typical cases, wider for outliers and extreme cases, empirical coverage, percentage of true outcomes within the predicted intervals. Prediction set size was based on the width of the interval, and conditional coverage, subgroup performance by gender, race, education, waist circumference levels, and external validation was done. The data sets were trained on the NHANES and calibrated and tested on the look ahead. Pre-processing, the NHANES data was tabulated, the lookahead data was tabulated, one-hot encoding for categorical variables, standardized for continuous variables, missing data exclusions, split into 50% training, 25% calibration, and 25% testing. Lookahead was 50% calibration and 50% testing. Grid search for hyperparameters was done by a 10-fold cross-validation, and separate upper and lower limit models for conformal predictions. And they were compared to point predictions, which were done with XGBoost and Shapley values for feature importance. XGBoost is one of the most recommended techniques for machine learning predictions. Results. In the NHANES, in the training data set, there was a very good coverage of 95.5% in men and 95.4% in women. Adaptive interval widths were larger for extreme values of waist circumference, but narrow values were there for average intervals with higher alpha values. Consistent performance across subgroups. Only Hispanic men showed marginal undercoverage. So you can see from the NHANES, data set, you can see on this graph, A, B, C, and D, 4 charts. The A chart shows the true outcome, and the one shaded in the blue shows the conformal prediction 95% interval. And you can see that as the waist circumference increased, the width of the blue bars or the blue gray shaded area increased. On the chart B, you can see that if the alpha, is lowered to 0.01, then the width of the interval increases significantly. But as you go to a lesser alpha value, a greater alpha value, you see that the width of the intervals go down. And you can see the density of observations. The top A and B represent male, and the bottom C and D represent female. And you can see that across the board, there was very good empirical coverage at alpha is equal to 0.05 for the NHANES data set with the shaded blue region being uniform. Now, look ahead coverage was 95.1% in men and 95.2% in women. So that was pretty robust in our data and training models. So the interval widths are larger than NHANES because of the population shift. The NHANES was the general population, while the look ahead was the persons with diabetes. So subgroup coverage, 95% under coverage only at waist circumference extremes, demonstrated robustness across domain shifts. So here you can see that coverage and prediction interval widths demonstrated robustness of the conformal predictions model. But we can see that the blue shaded area is much wider in males and females when it was externally validated in the look ahead data set. But despite that, there was excellent overall coverage, and you can see that the interval size also increased with more stringent alpha. Alpha of 0.05 was pretty reasonable between 15 and 25 centimeter interval, But as you increased alpha to 0.01, it became much wider, close to 30 centimeters of width. So validation results from the look ahead, you can see that NHANES, in males and in females, NHANES with the training data set had good with both in with conformal and without conformal, but on the external validation of the data set of the model on the look ahead data set, you can see that with conformal predictions the width becomes much narrower, and no conformal predictions there's a wide width in the point estimates, and the range can be huge in any machine learning technique like typically XGBoost. And so conformal predictions significantly improves your uncertainty quantification and gives a robust interval of machine learning predictions. And you can see that with conformal predictions, the width is significantly narrowed in both males and females in the blue plots there. Achieved high coverage rates demonstrating superior performance, and you can see that if you look at race, education, certain ethnicities had a better alpha coverage compared to others, so it goes to show that the model performs differently in different socio-demographic circumstances. External validation, again, in certain situations, the coverage was pretty weak, like Hispanics in male, and then other races in female. But overall, the model performed very well with very good empirical coverage, and you can see the cutoff of 95% overall. And certain BMI levels have better prediction, like 120 to 130, for example, for males. And but as the BMI goes down, or BMI goes very high, waist circumference goes up or goes down, you can see that the coverage rates drop down. So results: NHANES conformalized and non-conformalized coverage was 95%. Look ahead, non-conformalized underperformed. Conformalized models recovered expected coverage after calibration, confirms advantage of conformal prediction under data shift. So the most important aspect in machine learning which we encounter is domain adaptation and data shifts, where the training data set might be vastly different from the testing data set, and this is where these kind of techniques help. XGBoost has high accuracy in NHANES. Look ahead had lower accuracy, especially in females, with distribution shifts. Weight was obviously the most strongest predictor of waist circumference. Height was a negative predictor controlling for weight. And then age had a positive association with waist circumference. And you can see from the point prediction values that point predictions can be scattered around a perfect model. Look ahead had an R-square of 0.78. NHANES, where the data was trained, was close to 0.9 in both males and females. And then the Shapley values did show that weight and age were the most important predictors of waist circumference. So strengths: first, application of conformal prediction to obesity research, robust across data sets, clinically interpretable with uncertainty quantification. Limitations: cross-sectional data, no causality established, excluded diet and physical activity, but we wanted to keep the variables limited so that we wanted to get good machine learning models with minimal practically obtained clinical data. External validation was limited to look ahead. Measurement variability in waist circumference remains an issue. So how do we measure waist circumference in the first place? and how was it obtained with proper standardization techniques in the clinic setting is very important. Clinical implications: reliable weight circumference predictions without physical measurement, reduces interoperator variability, facilitates integration of waist circumference into clinical practice, and improves obesity risk stratification across diverse populations. And then future expand validation across more diverse data sets, incorporate additional predictors like diet, physical activity, biomarkers, develop EHR-based decision support systems, and explore utility in pediatrics, geriatrics, and other minority populations. Waist circumference is critical, but underutilized cardiometabolic biomarker. Machine learning with conformal predictions enables accurate, reliable, uncertainty-aware waist circumference predictions, potential to transform obesity risk assessment and clinical adoption. Acknowledgements: we really thank Look Ahead that has supported us, NIH and NIDDK that has supported us for so many years with their data sets. And we have had many successful manuscripts and publications. This is one of the most recent and novel one of them. And thank you very much once again.
Well, thank you to the presenters. I will like to invite both of them that remain here, because I think Emma Mauli had to leave us this afternoon. Dr. Guerra, are you still here?
Yes, I'm still here.
Okay, so I think we have a couple of questions on the chat that I would like to bring up. I think that one of the questions that was asked first was directed to Dr. Guerra, and it was in regards to the use or exploration to validate the results of your AI analysis. For apart from exploring the factors that you identified.
So to answer that question, my understanding is the question is about how do you validate the AI model that we extract the information from, and since this model is trained to predict X from X, what we do is we train it using supervised learning to minimize the what's called reconstruction error. So we take X on the input, X on the output, we compare them, and we use gradient descent learning to minimize that error. This is basically information reconstruction through information compression. And to top it off, to ensure robustness, we use tenfold cross validation, which is a state-of-the-art technique, pretty much gold standard for performing these processes. So that gives us a well-trained model. And now the clustering in projection, the extraction of information out of that trained model, that's another layer of establishing validity of the model. And that's where we generate, that's where we generate the explanation and the factors that help us, hopefully down the road, explain the mechanism of the disease that we're interested in.
Thank you. I think that definitely makes sense. I also wanted to follow up, perhaps bringing back to your presentation. Do you have any lessons learned from the use of the readiness of the data to use it and to maybe enhance your models, or how did you go about it? How difficult was it to use the data as it was for your model?
I think the biggest lesson learned, and one of the major cornerstones of this project, is we had to figure out how to deal with irregularly sampled and missing data. This is in my opinion, this is a #1 problem in all of the medical, biomedical, physiologic data. We deal with high-dimensional data. As we increase the data dimensionality, we increase the risk, we increase the likelihood of presence of missing data or absence of data. So that is one challenge that we had to solve before we set out to perform this discovery mission that we're on. So as I mentioned in the presentation, we use so-called fuzzy encoding to, #1, normalize all of the parameters into a unit hypercube, and #2, to represent missing data, which is one of the main challenges here. And one of the benefits of this approach that we have incorporated into this project, this fuzzy encoding, is we can extrapolate, we can generalize it to dealing with different data sources that do not contain all the same elements. So for example, if we have one data source, two data sources with different factors, and they have a number of joint factors, common factors, but some of the other factors are missing in either one, we can use this masking approach to fuse, to combine these, to train this model from these different data sources. And the big advantage, the standard way of dealing with missing data in biostatistics is using either listwise delete, which is a waste because we are basically discarding data that have at least one missing point. The other one is multiple imputation, which is a little bit of an exercise in futility because we try to first predict the missing data from whatever else we have, then use the predicted missing data to predict our outcome of interest. So I'm not a big fan of this approach. So long answer to your question, the missing data was the big challenge.
Yeah, I think that many will agree that missingness is a challenge for many. And it's not something that is exclusive to the data that we hold to be able to use it in AI applications. So for Dr. Santana, what about you? What were your experiences? And perhaps also another question to you as well is when and how you're planning to incorporate additional variables to your model?
So, this is what I think Dr. Gawada was very clear and very what he said. I mean, the more the models, the more you are going to experience training difficulties. Actually, we are working with a UK biobank data set with some collaborators with 450,000 people. And we are finding extreme difficulty in getting our model right with different, outcomes. And that's because the more the variables, it becomes more challenging. And also the utility of AI is in ability to do more with less things. If I were to collect more, say, body composition metrics like body fat percentage or more biochemical data, then I might as well measure waist circumference. So it's the utility of AI is in getting more out of less variables, but able to have what we call a domain adaptation, which means that it should be applicable, it should work for everyone, and it should work everywhere. For example, we now in this paper, we were very excited that the enhanced data, when trained and used in the conformal predictions, did very, very well in the look ahead data set. Next, we might try this in the Accord data set from NHLBI. So we are, trying to limit the number of variables. Does that answer your question?
Yes, definitely. But and you make a good point in a sense, right? Because I'm thinking, well, you kept it simple, and now I understand what you intended to do and why you kept it simple, right? Because if you complicate it, then it's might as well go and measure it yourself. Because then what is the gain? There's no gain if you are complicating things and it's more complicated. So I
Correct.
understand what you're trying to say and do, because if
So
there's no impact
yeah,
in the
so the other
result
thing
for
is,
adding variables there.
yeah, so I was also trying to say that in genomics, for example, they do numerous, genetic, um, you know, variables for limited set of outcomes, and then it becomes a real problematic about adapting and using it elsewhere in a different setting. So we want to limit that. So
Yeah, definitely makes sense. So there's a question that we have on the chat now, which is very interesting. Since this is for both speakers that remain today, since this data that you're bringing together come from different sources, can we consider them interoperable? I want to hear your take. I of course I have my thoughts, but what are your takes to both of you?
So does the CRIC data come from different sources?
Yeah, since the data come from different sources, are they interoperable?
Well, I don't have an off-the-cuff answer to this because I was assuming since the CRIC data were collected through one prospective study that they were, in a sense, pre-processed or curated by NIDDK. That's my understanding. So I don't have an answer to that.
So
would say,
Ravi, I think Ravi, if you want to come off mute and speak a little bit more about your question.
Yeah, basically what he said, the data you are getting from so many sources, right? So you don't know what kind of format you have, what kind of data you are getting, what kind of standards the data have. So I'm just wondering, how do you get this interoperability problem fixed? I mean, unless you're getting one source, it's okay. You have the standardized, format, the data standards.
so there are different techniques, for that. And for example, for this is basically what we call domain shift, right? Domain shift and domain adaptation. For example, CT imaging, AI learned by CT, is it applicable to MRI images through neural networks? Is the real big challenge in AI, is how do we adapt to different, domains, and that's the big challenge. There are no straightforward answers. For example, if there is underbalanced sample, we do SMOTE technique. If say there is an imbalance in events, for example, in a 10,000 population, there are only 500 events, and there is another data sets with 1,000 events in 20,000 population. There are, what we call SMOTE, synthetic minority sampling techniques. I'm a physician. I'm not a very big data, guru. I have a team of data gurus with me, but there are some techniques which can be used to do balancing of data sets in terms of outcomes. Dr. Gaveda may be able to answer more.
In my opinion, so this is something. This is a step that does not get enough attention, and it has to be performed. It's a must when you're dealing with data from various sources, from different sources. Before we start working on any types of models, all the data have to be standardized. This is a labor-intensive, time-intensive process, but it has to be done. We have to ensure with these models that we use, with any models that you use, all of the data have to be of acceptable, of decent quality. As they say, garbage in, garbage out. There is this sort of quiet expectation out there that with artificial intelligence, we don't have to do any data pre-processing. We just throw it into an AI model, which is quote unquote crystal ball, and it's going to do its magic and everybody's happy. That is absolutely not how it works. So this is my personal opinion. We have to invest in ensuring data integrity, data compatibility when we are dealing with different data sources. That is a must.
And that is exactly the reason we look to NIH and CDC to give us very high quality standardized data. If I were to train my model in my local tertiary center and use say EPIC data or EHR data, I would never be successful in getting a decent AI model out of it.
Yeah, both of you make a great point, and thank you, Ravi, for asking that question. And it's true, it requires a lot of pre-processing. It does not mean that data are interoperable. It means that you make it interoperable when you take data from different sources and you harmonize it before you enter it into your model. But it is a call to action to many of the submitters, the ones that generate the data for secondary users, because they are the ones that generate the data and have to submit those data with standardized and harmonized, I suppose, with some certain level of harmonization across, so that they can be used with minimum pre-processing to enable and facilitate new research, new secondary research. So I think it's an excellent point and a good way to, unless there are additional comments, I think it's a good way to end the conversation there. Other thoughts, comments? So I want to thank all of our speakers today. Thank you. I think that this was a great presentation. I am sorry that Dr. Mamauli had to leave. It was excellent presentation. But I think this presentation today shows a lot of the things that can be done with the resources that we have within the repository. I thank all the speakers for taking time from their busy schedules to speak to this and all the things that are possible with AI and ML. I know that there's, again, a lot of pre-processing that has to be done, but there's impactful research that can be done and that has real implications in real, I suppose, and to healthcare outcomes. So thank you again for taking the time. Next month, we will be speaking about real world data and the linkages. We are again going to be focusing on quality and reusability of resources. This is going to be on September 25th, and our schedule for that day is going to be between 2 and 3 Eastern Time. I hope that all of you are able to join us. Thank you.